Okay, I think we're going to make a start. So just to say, I'm using the microphone because this session will be recorded. So when it comes to the end, do be aware that potentially probably your voice in the back of your heads will be on the video, which will be up on the King's Global Health Institute website. Is that right, Anita? Yeah, brilliant, thank you. So it's a pleasure to see so many of you here this afternoon. I'm really happy to be able to welcome Jamie Murdoch to come and speak to us about process evaluation and how context is an influence and how context affects the implementation of interventions. And Jamie is a mixed methods researcher based at the University of East Anglia in Norwich. And he's also an advisor for the NIHR Research Service. Is that right, Jamie? Yeah. So I think we first came across, so I work for King's Global Health Institute, and we came across Jamie's work first in the context of his work with the ASSET programme. And the work around kind of implementation of guidelines for the management of childhood health conditions, working with Professor Lara Farrell in South Africa. And I think some of that is going to be some of the examples that Jamie draws upon in his talk today. So without further ado, I'll hand over to Jamie. There will be time for questions at the end, by the way, so we're hoping to have maybe 20 minutes, half an hour for discussion. Thank you.
Thanks, Rosie. Okay, is that working okay? Yeah, great. Thanks a lot for coming. So I don't know what everyone knows about process evaluation, so I thought I'd just give a brief background to what sort of questions process evaluations ask, why do we do them, why are they important. And then I'm going to talk a bit about context, because context is I guess, a central issue for process evaluation and implementation science. If you're involved with implementation science, or you've come across implementation science and you're wondering about the difference between process evaluation and implementation science, there's huge overlap. I'd say there are some differences. And I'm not an implementation scientist, but they definitely ask the same kinds of questions. And they certainly both consider what's the importance of context in our investigations. And in particular, how do we understand the relationship between how complex healthcare interventions are implemented and the context in which they're implemented. And I guess something that I've spent a lot of time thinking about, probably an unhealthy amount of time thinking about, is what do we actually mean by context? What does it actually mean? People use the word context a lot, but it's often really poorly defined, and people mean a whole bunch of different things. So I'm going to sort of talk about the sort of problems around that, I think, around translating theorizing of context into methods of investigation. I think that's where we really have fallen down, is that connection between theory and methods. And the way I've overcome it is using a methodology called linguistic ethnography, which some of you may have heard of because it was pioneered by someone at King's in 2004, Ben Rampton, who's in the linguistics department, and he and a bunch of colleagues, they run a summer school every year, and it's fantastic. And I'll talk about that in a bit more detail in a bit, but it's fundamentally changed how I look at healthcare interventions and how they're delivered. And then once I've done that, I'm going to talk about the Pact child study, which is, as Rosie mentioned, based in South Africa. And really, I'm just going to talk through an aspect of that study to demonstrate the points I'm trying to make around context. So, first of all, what is a process evaluation? Well, they most typically get used in randomized controlled trials, either feasibility studies or large definitive trials. So there's immediately one difference to implementation science, perhaps, is often we talk about process evaluation when we're talking about trials. And so why do we need a process evaluation, and what is it? Well, in a trial, you get a sample population, maybe people with diabetes or people with cancer, something like that, and you want to try out a new intervention. And so what happens is that the group is randomized to one group or another group, and group one receive this new treatment, and group two receive what's already in place, the standard care. And you get to the end of this study, and the people who've invested all their careers in testing this new intervention that they believe is the absolutely golden, the magic bullet to this problem, they get to the end of the study and they're praying that this is going to show a significant difference between the primary outcome that you're measuring, that it might be longer life or number of admissions, could be a cost effectiveness evaluation. However, what happens more often than not, I would say, is that there's no difference between the control and the intervention. And we spend millions and millions of pounds on these kinds of studies. And so what do you do? How do you explain that outcome when you find there's actually no difference between your intervention and control, or even worse, that the control is shown to be more effective than your intervention? How do you explain that? Is that a true reflection of reality? Or did something happen from this point to this point? How do you know that people in the control group didn't just speak to the people in the intervention group and go, oh, that's a good idea, I'll do that? So like an exercise intervention is a really good example where one group receives an exercise intervention, another group doesn't, but they all wanted the exercise intervention. So then the control group start exercising loads more, and you get to the end of the study and find there's no difference. So what you need is something to investigate what's happened. And that's what process evaluation does. It unpicks that black box, if you like, of this point here to point here. So arguably there's an ethical obligation to include process evaluation in trials, because if you get to this point and you can't explain this outcome, then what are you going to do with that? People have invested their time and money for that. And so process evaluation is about unpicking those details and getting into a lot of detail. So another way to look at it is if you ask someone to paint a picture, they might paint by numbers, they might join an art class and get detailed instruction, they might do something like Jackson Pollock and throw paint at a wall, or they might use their hands, or they might just stick the paintbrush in their mouth. So what you think people are going to do, how you ask them to do something, once you involve human behaviour, it can be interpreted in a whole different range of ways. And so therefore you need to understand how people interpret this thing that to you is really obvious, but actually to them it means something completely different. And so it's about engaging with human responses. It's about understanding how your intention is then taken by the people you're trying to work with. And the more people you involve, the more complex it gets. So the sort of questions you ask in process evaluations are, what is the intervention that's actually delivered? Is it the one you thought it was, or is it something completely different? And this is what's called implementation fidelity. Is it the thing that says on the tin, so to speak? And then what about the theory underpinning the intervention? Every intervention has a theory underpinning it. It may be explicit. People say, well, this has been informed by the theory of planned behaviour or COMBI model or something like that. Others just say they're testing an intervention, and it might be implicit within that, and you actually really need to tease out why are you investing in this intervention and not that one? What is it about this one that you think is going to work? So there's always a theory, and so process evaluation evaluates whether the theory underpinning the intervention actually plays out in practice. Is there fidelity to this theory? Or actually is something completely different happening? So process evaluation wants to understand that. What's the theoretical mechanism for this intervention working or not working, or that it works in this circumstance or not that circumstance? So clearly the target population is really important. How do they respond? And then can you sustain it over time? And I guess that's one of the key questions of implementation science. So that kind of sets out a sort of broad background to process evaluation. Now sort of thinking about context, there's been a whole range of different models and theories about how you understand the relationship between context and intervention, and these have gone back quite a few years now, and there's still more models being introduced, something like 62 I heard last week, something like that. So these are just a few of them, and they all differ in their kind of focus and how they think you should structure context and define context perhaps. But I'd say they all agree that there's a dynamic relationship between your intervention, your innovation, and the context in which it's being delivered, that these things aren't fixed, that you can't just implement something over here at this point in time and expect it to be the same if you deliver it a year later in the same place or in another part of the world. There is this relationship, and once you've implemented it, you change the thing that you're doing. So something gets produced, context gets produced. So there's this kind of dynamic interaction between time and space and the intervention that you're implementing. And I think there's general agreement across these different models that that is the case. The problem is, how do you translate that theorising of context and implementation into methods of investigation. And I'd say we've come a long way from this idea, which when I started doing healthcare research, you work on an RCT and they say, well, you just follow the protocol, it doesn't matter where you do it. Context is like this modifying variable. As long as you just follow the protocol, you should get the same result. We've got a large enough sample, so on and so forth. I think we've moved a long way away from that now to one where we recognise that actually the more complex your intervention, the more people you're involved, the more components it's got, the more you need to understand the system in which that intervention is being introduced. And we've kind of got to a point where it's starting to be viewed really as an event that disrupts a complex system. And Graham Moore, who's authored the process evaluation guidance, I really like this quote. He says, interventions are fundamentally attempts to disrupt mechanisms which perpetuate and sustain a problem in a given time and place, and hence cannot be described, let alone understood, in isolation from the systems whose functioning they attempt to change. So the point here is that you develop an intervention because you recognise there's a problem, and that problem is being sustained by a set of conditions, processes and forces. And so it's kind of to be expected that if you then develop something that's going to solve that problem, it's going to disrupt that system. It's not going to just be easy going, it's going to make a change, it's going to cause a disruption. Much like dropping a pebble into water, it's going to cause a splash. And so the task of process evaluation is to see if that splash is a big one or whether it just causes a few ripples. And you need to understand the system around it to understand the rippling effect. And so that's the kind of sort of theoretical view on the relationship between context and complex systems. Now, as I've been talking, you might be thinking there's a lot of like complexity and context and different words that get thrown around, and you know, I think that is the case as well. We've got complex interventions, complex systems, and we've got context. So what do we mean by each of those? And I'm not going to spend any time trying to address this first one right now, but I can talk about it later if you want. But I'm going to focus on the next two, is what do we mean by context? Are they characteristics, components, processes, or something else? And then how do we translate our definitions of context into methods of investigation? How do we show integrity to this idea that there's a dynamic relationship between intervention, implementation, and context? You know, how does it carry forward all the way through to our findings? And that, I would say, is a challenge. So this is, if you just look around at the literature, this is a range of different ways context gets defined. Most typically in health services research, I would say context gets defined in these ways. It's setting, it's demographic factors, it's the location, organisation, maybe the individuals involved. Most typically you see that kind of conceptualisation. If you move out of health services research, you start to see different ideas about what context is. You start to see things like it's the social political organisation, or it's broad social forces or cultural activities, or it's language that is produced through interactions. And that is a far cry from, you know, the idea of context as just being demographic factors. So this is a problem because I don't know where to look then if I'm going to do an investigation of context. What do I pay attention to? What counts as data? When is something context and when isn't it context, and what's relevant? And if you're going to design a study and you've got to think about the methods of investigation, then am I looking at language? Am I just looking at the location? So I guess what I've done is to go, okay, so people generally agree that there's this dynamic interaction between context and implementation. Well, some of these just look like steady state fixed characteristics. Location is, you know, it's a kind of thing. Deprivation, it's a kind of state of a community, high level of deprivation, low level of deprivation. Some of these are just characteristics, they're factors that are static. Now, if you want to understand a dynamic relationship, that's not very helpful. Maybe we need to understand how context becomes meaningful to people. So this is actually a logic model. Most typically, if you're familiar with logic models, they tend to be quite linear. You have things like the resources, activities, and it's kind of all the way to outcomes on the right. You see this linear model. But this is kind of reflects the complexity of contextual factors around smoking. And I know you probably can't see a lot of detail here, but you can see that it's represented in terms of process, in terms of forces, what context actually does, not what context is. It's not to say that things like demography aren't context. It's just that it's more fruitful to look at what they do. It becomes meaningful to people. If you live in a highly deprived area, it becomes meaningful when you can only access a healthcare clinic that can't provide any care for you. That's because of where you live. It becomes meaningful through action, not through something that's fixed. So here we've got what influences smoking behaviour, and we've got things like government awareness of tobacco, anti-smoking legislation, tobacco growers. And so it represents this kind of dynamic nature, this relationship, these forces that interact with one another. So context can be viewed as a social process and forms of social action rather than characteristics. And this is where the problem is, I would say, is that the methods available to us are limited. We tend to go and do interviews with people on a particular day, and we sit in a room, we ask them a bunch of questions, and then we say that represents that person's view. Even if you take a critical view to the nature of qualitative interviews, that's what you're doing on that day. And then you go and interview 20 other people, those are snapshots on that day. You might then go and do some observations. They tend to be on a day. So where is this dynamic process we've been talking about? So Sengi said, complex organisations are bound by invisible fabrics of interrelated actions. Since we are part of that lacework ourselves, it is doubly hard to see the whole pattern. Instead, we tend to focus on snapshots of isolated parts of the system and wonder why our deepest problems never get solved. The essence of mastering systems thinking lies in seeing patterns where others only see events and forces to react to. And I really like this one. It's from 1983, which really, picked up on the limitations of a lot of research methods. That observations and interview methods take snapshots of implementation, the timeless present that freezes society at the point of observation. And that's what we tend to do. And then we try and link it back to these models and talk about dynamic interaction, but yet what you've done is produce something at a particular moment in time. So, how have I tried to solve that problem? I still do observations and I still do interviews, but it's what do you do with that data, I think, is a way around that. And so linguistic ethnography is really a fantastic movement, I would describe it as. It's combined the strengths of linguistic and ethnography, and it comes out of linguistic anthropology that was developed in the United States in the last century, predominantly from Del Himes. And Ben Rampton, he develops linguistic ethnography alongside a bunch of other people. And it really was about understanding human behaviour in context. And a central premise of linguistic ethnography is to take context seriously, not to assume what context is, but to investigate it and show what empirical data for context, what is it? And it provides tools, in particular, for how meaning, talk, text, objects shift over time and place, which is what I'm trying to do, really. So I found this has got a lot of traction in process evaluation. There's three things that I found very useful. First is this idea of context as a social process. And Michael Burroy wrote a brilliant paper called The Extended Case Method that looks at single cases, not in isolation, but tries to trace a path from macro contextual features right down into how someone is talking. And he said people invoke macro structures in their action. So what you're seeing when you see someone behave is not them as an individual or solely as an individual. You're seeing them drawing on macro structures through their talk. So immediately, once you recognize that, you're tracing a thread from individual action to broad contextual structures. And so the challenge is to then observe that. Then the second thing is an idea called text trajectory analysis. And this is the idea that texts are very powerful. Now in healthcare research, texts are just everywhere. They're absolutely everywhere. We've got policies, we've got guidance, standing operating procedures, protocols, we've got checklists, we've got medical records. We've got computer decision support software. We've got equipment that produced charts and outputs and measurements. Texts are everywhere and they're very powerful. They represent people and they go on journeys. They start in one place and they finish in another place. And a person and a patient, he travels or she travels all the way along that journey or part of that journey. And their life is fundamentally affected by how a checklist is completed or a piece of equipment produces a score about some test that they've undergone. So texts are really powerful. That text then gets taken elsewhere. Someone looks at it and goes, oh right, you've got that. You're going in that direction and you're going in that direction. So you can trace a path from where texts are created to where they're fundamentally used with patients. And they often are emergent out of debates, policy debates, academic debates about what we need to measure, what we need to focus on, and that is consequential for what happens next. And then the third thing is this idea of disruptions. Well, we've talked about interventions as events that disrupt complex systems. How can we observe that? And so linguistic ethnography has a set of tools or a way of thinking about observational data in these terms, that disruptions to social action, they expose social forces. So rather than doing a thematic analysis and looking for patterns, you're actually looking for where things break down. It's a completely different strategy, and the reason for that is because it exposes something that is hidden. So if you imagine, we all know emergency services are there, we know the police are out there, ambulance services, fire services, but we can't see them out the window right now. But if someone let a bomb off out there, you'd see them in 2 minutes. And the social order of our society would be exposed through this disruption. And in healthcare research, it's the same. As Wittgenstein said, and I have used quite a few quotes, but I do like good ones, the aspects of things that are most important for us are hidden because of their simplicity and familiarity. One is unable to see something or notice something because it's always before one's eyes. And this means we fail to be struck by what's once seen is most striking and most powerful. It's kind of hidden in plain sight, that idea. So what I've done, the approach I've taken then, is to map out macro, meso, micro contextual features, providing a structure to context, and then try to consider the relationship between macro all the way down to micro, and including texts, protocols, guidelines, discourse, policy. And then to target where disruptions, tensions are likely to occur between different contextual features and the intervention that you're implementing. Is it compatible within this context, or is it going to really cause a major problem? Where's it going to cause a problem? How is it going to happen? And once you can kind of speculate prospectively, you can then go and investigate it. Where are these disruptions likely to occur? What sort of activities? Is it in the consultation room? Is it in a training activity? Where's it going to happen? And then once you've done that, and you've found these disruptions, and you've exposed this social order, hopefully, then you can consider the implications of this social structure for implementing and sustaining the intervention. You can come up with theoretical propositions about how to make it more compatible. If we change this contextual feature, the intervention will fit. Or if we change this aspect of the intervention, it's going to be more compatible with the healthcare system. The ripples won't be so big, there'll be small ripples. So, now I'm going to talk through Pact Child Study as an example. This is nearly finished now. It's been going 2 years, led by the Knowledge Translation Unit at Cape Town University. And it's all about health system strengthening around paediatric primary care, primarily using what you can see here is a guideline. So it's a book which covers a whole range of different conditions. And it came about because of the sort of recognised limitations about existing policy and practice around the sort of tackling child mortality. So over the last 20 years, the integrated management of childhood illness has been adopted and implemented in primary care in a lot of low and middle income countries to tackle child mortality, and has focused on acute illness, malnutrition, growth, monitoring growth development, supporting young families, and it's focused on the under fives. But some problems have been recognised around people sort of following IMCI closely. The fact that it's focused on the under fives doesn't support children over sort of 5 and above. And also it doesn't really tackle long-term health conditions. That's kind of missed, really. So Pact Child was developed to address those gaps, to extend IMCI, not to replace it, but to complement it. And it's a guideline that covers 63 symptoms, 16 long-term conditions, most commonly seen in primary care. And it's designed for consultations for children up to 13, so above 5, and includes 9 on-site training sessions, and it's about identifying priority content, case scenarios, and supporting staff to use Pact Child in practice. It's about, giving them more skills, really. And so the process evaluation objectives are all of these, but I'm just going to focus on the first one here, is how does the social context of paediatric care influence how Pact Child was actually delivered? How does it really get embedded within this system? Where do you see these disruptions taking place? And then the fourth one, what can we learn about how to optimise Pact Child? So it's been implemented in 10 primary healthcare clinics in the Western Cape in South Africa over 3 phases. In 1 clinic, then 3, then 6. And so the participants obviously are children and caregivers, nurses, doctors, policymakers, paediatric managers. And so there's a whole range of methods, which are the ones where we talk about this snapshot of implementation. We've got observations and interviews and focus groups. But it's how we analyse these data, how we conceptualise them, and where do we look, what do we pay attention to. So first of all, we've sort of done this context evaluation. I'm going to talk about that. And I'm going to talk about question response coding of consultations and this disruptions. Thank you. So first of all, how do we then theorise the sort of implementation of Pact Child within context? So what I've done here is to then break context down by macro, meso, micro contextual factors, and try to map out what are the key things that are shaping at the point of delivery. Now, the point is not to map out every contextual feature, otherwise you'd be working to the end of time. The point is to pinpoint what do you think are the key contextual forces that are shaping the point of delivery, and how can we see this as a process? That's our objective. But it's a force that influences from the macro to the micro, and then also in the other way, although that's kind of harder to understand or get your head around. It certainly has been for me. But first of all, we've got the sort of policy around IMCI, which is around risk management, focusing on acute illness, viral infections quite typically, growth monitoring, malnutrition, that's kind of stuff, immunisations. So that's a big policy that's been implemented in primary healthcare clinics. Nurses have had limited prescribing. They can't prescribe things like inhaled steroids for children with asthma. Limited chronic illness training, so it doesn't really happen in primary care. And Pact Child is trying to then change that. That's what it's trying to do. But it's also trying to introduce treatment of behavioural and psychosocial problems, which is something I'm going to show in a little bit. And then at an organisational level, we've therefore got nurses who are IMCI trained. If you've got an IMCI policy, you therefore need to train people in IMCI. So here we see that it influences what happens at a primary healthcare clinic. The focus of their training has been on under fives and on acute illness, immunisations and growth development. It hasn't been on chronic illnesses. So here, this is where this gap is happening. And there's other things which are important to pay attention to, such as staff are frequently rotated to ensure access, but may compromise continuity of care, perhaps. And then we can understand at a micro level how this shapes what happens in an interaction, in a consultation. Nurses will attend to IMCI, we can argue, the IMCI policy. They have to complete a checklist, which is audited. So we see this text trajectory from a policy to a checklist to an interaction with a caregiver that demands that the nurse ask certain types of questions, because that data is going to be monitored. Are you doing the things we're supposed to be doing? The provinces in which these clinics are located require that nurses do that. So that's kind of broadly speaking how we've kind of conceptualized the contextual framework. This is a page from the Pact Child Guide, and it's arguably the most important page in the guide. It's to be used in every consultation, and it introduces a different structure to the consultation, where normally a child might present with symptoms that are then treated. Here, Pact Child is saying, child presents with symptoms. If it's not an emergency, then you kind of park the symptoms and then switch to routine care. And then you come back to the symptom at the end of the consultation. But in every consultation, these are the things that have been missing, or a lot of these things that have been missing, which Pact Child is trying to target. So it wants to make sure these things get asked, and that's why you've got this different structure. So there's a lot of stuff which is on the IMCI policy and within the checklist, but it also introduces questions about the mother, HIV status, contraceptive needs, TB symptoms, but then ask questions, psychosocial questions, such as violence in the home, family support, financial difficulty, and then mental health problems for the child, school problems, behavioural problems. So it's introducing some really different types of questions here, and this is where there's a real gap. So these questions need to be asked. So the issue is, how does this work alongside documents like this, which is the IMCI checklist? So here we see check for danger signs, cough or difficulty breathing, diarrhea, fever. So this is this focus on acute illness, and you've got to complete this checklist, which therefore requires you to ask questions in a particular way to get your yes/no type answer. And then the third document that is used within consultations are the Road to Health booklet, which is like a medical record, a paper record which the caregiver brings. And this is where you record the child's development and you note immunisations. So that's just one page. So you can see there's 3 different texts in operation within these consultations. So this is an observation of a waiting room that provides some understanding of what it's like outside a consultation. So here what you can see is the waiting area. I'll stand this side. And there were about 250 people, I think, sat in there when we went in at 9 a.m. or something like that. About 50 to 60 children, but only about 2 or 3 of them are over 5 years of age. Here is a triage desk where a sort of student enrolled nurse asked 3 questions, and we stood there for 2 hours and they asked the same 3 questions. How old is he or she? How much do they weigh? What is the problem? And every one of those children presented with symptoms that suggested a viral infection. None of them presented with, I'm having my asthma checked, my child's been behaving in a weird way and I'm concerned about it. It was always about acute symptoms, nothing else. And they waited there a long time. They spoke to the triage desk and then they'd go to one of the 2 consultation rooms. So this is just one observation on one day in one clinic, but what this starts to raise questions about is how is this type of clinic orientated towards sort of what Pact Child is trying to do? How compatible is this new intervention going to be with a setting where everyone's presenting with acute symptoms that suggest viruses? It's a very busy, noisy environment, and people are going to be waiting a long time. And the questions that are asked are very much about, growth monitoring and what's the problem. So it does raise those kind of questions. Is it, I guess the sort of idea in your back of your mind is it institutionalized to present and treat acute symptoms? Where are the children who are over 5? Why are they not here? Have they gone elsewhere? And there may be legitimate reasons for that, but it then you start to think, well, how is Pact Child going to fit with that? So now I'm going to play you 3. Oh no, I'm not yet. Just show you the question response coding. So what we did with every consultation, we coded every single clinical assessment question. And the reason for that is because when someone presents with an illness, a key part of that is the clinical assessment. And we used a method called conversational analysis, which you may be familiar with or not, but it transcribes the details of what people say and just looks at the sort of turn-taking sequences. And we coded 9 different categories, and I'm going to focus on question type and semantic structure because there's different types of ways of asking questions, and some of them are called polar questions, and I'll come on to that in a second. What we found when we did this coding, we coded across these 9 different categories of wider information gathering, feeding, asking about TB, HIV, the reported problem, psychosocial issues, because that's what Pact is trying to address, other treatments, family planning, past medical care, and eliciting patients' concerns. And what we found, I'm just going to focus on 3 features of this. First of all, the most commonly asked questions were IMCI type questions, which is not really surprising if nurses are being trained in IMCI and have to address those sorts of questions and have checklists that they need to complete that is then going to be monitored and audited. So most of the questions were around reported complaint, TB, HIV, feeding, and wider information gathering. The second feature of this is around psychosocial questions. So there were 157 questions asked around psychosocial problems. 85% of those questions are what's called polar questions. So they're closed questions, but they are separated into 2 different types. You get interrogative and you get declarative polar questions. And the thing about polar questions is that they lean towards one answer or another. So an example of an interrogative question would be, any vomiting at all? So it's kind of like leaning towards the absence of vomiting. Any is kind of like a sign of leaning towards a no. Whereas a declarative question, it's written as a statement, but it sounds like a question. So no rash. So it's a statement that is actually a question. But again, the answer's in the question. No rash, the absence of a rash. Another one would be, and she's drinking water. Again, that's a statement, but you're actually asking a question. So 85% of psychosocial questions were asked to kind of prefer a particular answer. They weren't asked as content questions, which are like what, how type questions, which encourage talk. So this is interesting because it says, well, why are questions that are meant to be eliciting psychosocial problems being asked in closed type questions that presuppose an answer? Why is that happening? And then the third interesting feature is that questions about past medical care, there were only 9 out of the whole sample. I've excluded TB and HIV because you get lots of questions about when you were tested, but you get hardly any questions about you went to hospital, when were you admitted, stuff like that. And there were virtually no questions, only 6 that asked parents what they thought, what their concerns were. So what you start to get a sense of is that it's very much focused on acute illness management, this IMCI policy. It's asking questions that are quite difficult to get psychosocial information perhaps, and there isn't much looking at beyond that on-the-day episode. There isn't much elicitation of past medical care or the parent's perspective. So that kind of gives you signs or clues about where to look in the transcripts. So what I'm going to show you are 3 transcripts now that show some of these issues. So the first one is a 3-year-old girl who's presenting with a cough. And so what we're going to see here is the nurse asking questions that are prompted by the 3 different documents, Pact Child, IMCI, and the Road to Health booklet. And on the right, what the researcher's done, he was sat in the room, that she noted every time the nurse used one of those documents and when, so then you could synchronize it with the transcript. So you're seeing when the nurse used the document at the point where they were talking, okay?
No diarrhea, no? Okay. And feeling hot at night or during the day? No. Okay. And can I see your hand and the baby's hand?
Yeah.
Okay, thank you. What is your HIV status, is it? Your HIV? Negative. When did you?
You were the one who did last month. When I come with Mimi.
Okay. Okay. How old is this baby first?
She's 2 months.
Okay. We go to a content page, which is page 50 for cough, and also we go for routine care, which is page 14. She is, how old is she now?
2 years and 3 months.
2 years and 3 months. 2 years is here. We must check the weight. Let's set the weight. Weight is 16, and the weight haircut is here. Check the weight. Hi, boss, you see you coughing, ne? 16 point. Let's plot the weight. 16.6. She's 2 years and
3 months.
3 months. In March, April, May, June, July. And it's 16 point, sorry. Which is 60.6 here. She's growing very well.
Okay, so what this is kind of showing really is the work the nurse has to do in one of these consultations, because she's required to use this Imci checklist. She's now trying to use Pact, which is slightly different structure. There's a routine care page that I showed you before. She actually uses the routine care chart. And she's also trying to use the routine Road to Health booklet at the same time. So what you can see is that there's switching between different documents. You can hear her flicking through the pages. There's, in this transcript with these colons, they emphasize elongated vowels, which often, when you hear it, it sounds like the searching. Okay, da da da. It's like this searching around the documents, navigating it. And there's lots of silences. You've got a 12-second silence there. So this type of transcripts, it starts to give you a picture of the sort of what's going on for this nurse. And there's a lot of time being spent navigating these different documents. And of course, one thing that you can immediately say is like, crikey, maybe we need to reduce the amount of paperwork she's having to deal with. Maybe it's really a burden, and that's absolutely, the case perhaps. And it takes her 10 minutes to kind of get through this, and then eventually says, right, well, now we're going to go to the real problem. And so this is a consultation that takes quite a long time. But the other way to look at this is like, well, what we're seeing is IMCI policy and Pact Child policy coming together here. And it's not completely incompatible, but it's not exactly blending really well. It's definitely difficult. It's hard work. And if you've got a waiting room full of 60 children, you perhaps haven't got time to navigate all these different documents. It's really hard work. So this is where you start to see these kind of disruptions occurring. And the second transcript is specifically around psychosocial issues. So this is a 4-year-old who's got sticky eyes. There's a father and a mother brought their child into the clinic, and the nurse is has asked questions about the child's symptoms, but is now working on the routine care page and is going to ask these psychosocial questions, which completely come out of the blue. There's no preparation for the parents. So just look at how she asks those questions and what happens. Okay, so if you imagine this, you can hear how busy this clinic is. You've got the mother and the father in the room, and the nurse is suddenly asking questions about violence in the home, potentially. Or that's what she's reading, and she's translating that into, at home, is there any problems, whether it's financial or no problems? And you're getting well together in the house. Yeah. So these questions are delivered as declarative, polarized questions with the answer in the question. You're getting well together in the house, just say yes. And you're coping with the baby, no problems. Okay, so the answer's in the question. These are questions designed to not have a lot of discussion. These are designed to rule out the problems, and you've got the mother and the father there, so it's kind of like, are they really going to disclose under this situation? So, one interpretation would be, well, maybe this nurse needs to ask the questions in a different way. But actually, if you consider the circumstances under which she's working, and the fact that this is parents who brought their child in with sticky eyes, this is a very difficult set of questions to suddenly ask somebody, but yet they need to find out these issues. These are the big problems. So what happens is that her response is to ask these sort of polarized declarative questions that are no problem questions. And what's amazing is that you can do a piece of research in South Africa and you can do a piece of research down the road here, and you'll see the same sort of questions when people are pushed for time. They ask no problem questions to rule out problems quickly, not rule in. It's an adaptive strategy, and people go along with that. No problems, no problems. And what's interesting as a point of contrast is this third example. What happens when someone actually discloses lots of psychosocial problems? Is this context, is this healthcare system set up to deal with psychosocial problems when people actually disclose them? And so this is what happens in this next extract. This is a 12-year-old who's come with a sore throat and high temperature, I think. And it's a grandmother, and she starts saying lots of stuff that is way beyond the sore throat. And the question is, what does the nurse do with that? So, yeah, I mean, clearly, you know, this grandmother's introduced lots of problems in the child's home, relationship problems with the mother, absent father, violence, behavioural problems in school, earlier mentioned bullying. And it's like, what do I do with this? You know, is this nurse working under this situation equipped? And so she's got the Pact Child Guide, which is designed to deal with these problems. There's specific pages, but it just sits there with the contents page open, and she doesn't move beyond that. Again, you could say, well, why didn't the nurse do that? But then if you consider the context under which she's working, actually it's very difficult to move out of this experience of focusing on acute physical symptoms to one where you've suddenly got all these psychosocial problems. And it's not that she's expected to come up with a solution, she needs to make a referral. But it just emphasises where these disruptions are occurring between primary healthcare clinics that very much focus on acute illness management, growth development, immunisations, and an intervention that's trying to make a transition away from that, trying to focus on long-term health conditions and incorporate a focus on behavioural problems, psychosocial problems. And so, you know, clearly there's some way to go with that, and it's about understanding, you know, what are those interactions that are going on. And so we can kind of conclude from some of this, or at least hypothesize, that the nurse's talk at the point of delivery exhibits these tensions between this acute illness focus of primary care clinics and Pact Child, which incorporates this routine care, which is focused on holistic care of the family and psychosocial conditions. And so what you see as a result, this is where the disruption is manifested in the talk, you see these no problem polarized questions seeking confirmation that no problems exist, or they revert back to an acute physical problem. It's being able to deal with what you can on the day. And so how do you then take that forward? Well, you can argue then that more effective integration of this intervention, continuity of care, identification of chronic illnesses, mental health, etc., will be enhanced perhaps by a policy that promotes ongoing healthcare management. So that's an intervention at a macro level. We need to shift the policy away from an acute focus and just on the under fives to long-term health conditions over the life course. Understanding that it's not just one episode, but actually we need to get a picture over time. Of course, there's a burden of paperwork that needs to be dealt with, and integrating different stationery, or you could draw on other members of staff to deal with some of the other stuff, such as IMCI. Maybe the enrolled nurses could tackle some of those questions, so the nurses in the consultation room can do much more of what Pact Child is trying to do. So these are interventions that are at different contextual levels that then should have a consequential effect from the macro down to the micro. And of course we want to, training is always part of these interventions. You know, how do you elicit psychosocial problems? But unless you change the policy perhaps, or change something at an organisational level, that's still going to be an issue. You're still going to arguably see people adapting to their circumstances by asking no problem type questions. Unless you change the system, you're not going to change the behaviour, I guess is the point to be made there. So that's the findings from that study. So I guess what I've tried to show is that process evaluations are really about unpicking the observed effects of trials, but it's about specifying the circumstances under which something is going to be successful. And one of the main challenges is about taking conceptualizations of context into methods for investigation. And so I think one way in which you can do that is by searching for these disruptions and the power of texts, because texts go on journeys, and disruptions, they expose something much more than the individuals involved and how they're performing. And if you can do that, then you can generate theoretical generalizations for improving implementation that are, you know, about changing the healthcare system as much as changing the intervention itself. Thank you. Just need to acknowledge a few people. There you go.
That's great. Thanks so much for that, Jamie. It's fascinating. I feel like I hear something different each time I hear your talk, so that's really great. Thank you.
Hopefully it's consistent.
Yeah, I'm just noticing new details. Okay, so is there any questions at all? So maybe I'll get the ball rolling. I just wondered, so I had two questions. So one was about kind of thinking beyond the health service and the health system, I guess, and broadening out that conceptualization of systems, and having a think, I guess, about the role of the patient or the service user within this, and about their kind of readiness to bring a chronic health problem to an acute service or a psychosocial problem to the health service. And I don't know whether any of us have any answers about this, but I was wondering a bit about what your work with Pact kind of said about that.
That's a really, really good question, because it goes back to this thing I was hinted at earlier, is that we can look at context as being shaped, or what happens in a consultation room as being shaped from a macro level down to a micro level. But actually it does work in the other direction, and you could, you know, do something within a community, for example, about where do you go when your child has this problem, and what type of problems do you have? Is it just acute symptoms? And I'm sure you'd find out very quickly there's a lot more that's going on with many children's lives. And that type of intervention is much more local, it's much more micro, and you could change how people interact with their local healthcare facility. And that would be some kind of strengthening at a micro level that might then feed back upwards. So people keep presenting with these problems. Okay, we need staff who are trained to deal with these problems. We don't know how to deal with this. And then that changes perhaps policy around that. So I think that's a really important point, is that we need to think about how ready people are to actually talk about these sorts of things. They might be really difficult for some people, and it's not normalised, they're not used to it. And maybe in some situations, but not in these situations, it seems. It's not become part of the convention of what happens when I go to this clinic and I speak to a nurse. I know what happens. They ask me about the virus, and they ask me when I had an HIV test and how my child's growing. That's what they ask.
Yeah. And I think it becomes a slightly circular thing, right? Because I think we've all heard of examples of people maybe opt to go to something that is available within their community, and which maybe is a bit more appropriate for that kind of chronic care model if they're depressed, for example. So it might be a priest, it might be a traditional healer.
Yeah,
and
that's right.
I guess there's a tension between kind of, should the health system take over all of that role, or should there be
kind of they may not see it as appropriate at all, actually. So something, I think, they're certainly having a sort of stakeholder engagement in the next couple of weeks, actually. And there's been a lot of discussion about how do you involve caregivers, not just for psychosocial stuff, but just about long-term health conditions and how you use this guide in a consultation. So it's an important step, without a doubt.
So just one last question from me. Oh, sorry, no, go ahead, Shelley. No, please, go ahead.
Thank you. I just wanted to say it was a very powerful talk. I really enjoyed it.
Thank you.
I wanted to say that this is really giving us an opportunity to think about research methods differently. I'm talking from an implementation and a research hat. So it definitely gives us an opportunity to delve into more of the nuances, not only effect and outcome, but the process. But it also rather increases my cynicism for global health in general about, because all the interventions are always targeted at reorganizing the health system, for example, primary care, and trying to impose guidelines and tasks more for the nurses and frontline workers, because eventually it nails down to that. That's how I see it, at least. And and then there comes the concept of integrated care and integrated chronic care models at primary care, for global surgery to mental health to malnutrition. So my question is how in Pact Child and other Pact programs this was addressed, and what do you think is the way forward for similar global health projects moving on?
When you say how was this addressed, do you mean how did it move beyond giving nurses a guideline to follow, or?
Yes, like giving them simple guideline, but again increasing their workload in terms of like HMIS that they have to do, and also the psychosocial delivery as well. Like in primary care, nurses would have to deliver psychosocial interventions. So how does it address that and moves beyond, and how your research methods would reflect on that?
So that absolutely was thought through at the beginning, but what they've learned is perhaps not enough. So they had these 8 training sessions to begin with. Then it became clear that there was a workload issue. They then added another training session that was called Health System Strengthening, and it asked everyone in the clinic to map the patient flow through the clinic and figure out how to reallocate tasks, so to reduce the burden on staff and to make it more possible to actually use Pact Child within interventions. They also asked them to look at documentation. How do you deal with a situation where you've got to complete certain paperwork that is required by a province? Do you need to complete it? Some clinics actually were able to put it to one side and just use the guide, and then we can look at perhaps how that's different. So it definitely thought about that, and there was also constant sort of feedback from staff about using the guide. We don't like that bit needs to change, I'm not used to this bit, this doesn't make sense with what I've been taught, and so there were constant refinements of it. And so there was constant feedback in that respect, but it's by the end of this study, and it's by looking at the observational data, that I think it's really shown a light on what's perhaps being missed, and that actually if we'd done it again, there would have been much more of a diagnostic phase really about how the health system could be strengthened to support Pact Child, which isn't just about here's another guideline, and that's one of the main things that we've kind of recognised at the end of the study. And so they're actually thinking about doing a different focus, different group, but instead of doing the same thing again, there's a diagnostic phase that is being built into it before we actually pilot the new guideline that's going to be evaluated. Does that answer your question?
Yeah. Does that involves like buy-in from the government? I know UCity has a lot of collaboration with the national level stakeholders.
Yeah.
But is the government buying in?
Well, there's lots of discussion, and yes, they are very supportive in principle.
That's nice.
But it's about what do you take next, and what I'm learning, because I've done research in the NHS prior to this, I'm not used to these kind of tensions, is what do they really care about? What sort of message do you need to engage with? And where does Pact Child fit with that? So you've got to focus on their agenda and what is achievable, in other words. We can't just say necessarily, the healthcare system needs to change. Do you know what I mean? It's like, that's not going to happen, So you've got to be strategic. Yeah.
It's nice to have a theoretical underpinning from the point of view of the method that you described. very soft recommendations in the end, like superficial. But for these recommendations, I think this method gives kind of a theoretical underpinning as well, and coming from all the way from methods to the analysis, as you said. So thank you.
Thank you.
Cheers.
Thanks.
Any other questions at all? Just Kenzie.
Hello, thanks for the presentation. I just want to ask about if you had a chance to ask about experiences of nurses who were using these different tools to assess patients. Of course, through your discussion, you said that, of course, it's quite complex, and I agree with you, but what were the views from the nurses themselves?
Yeah, we've done a load of interviews with nurses to find out their views. And some, on the whole, it's positive. They think it's really supporting their decision making, giving them confidence in how to manage different conditions. But some of the things that we've observed around the burden of paperwork that's come up, and being able to do everything that Pact Child is asking them to do within a consultation. Some of it's been about, this has helped me monitor growth more effectively. Some people didn't feel very confident in some of the stuff that IMCI was supposed to address. They actually felt their skills were enhanced through the training. So it's been, some really positive things, fostering sort of collaboration between members of staff as well, but also some real challenges, in how do we actually do all the things that you've asked us to do here, and how do we really support children? And some of these questions are difficult. They've said, it feels really difficult asking these psychosocial questions. So I'd say, what we've kind of observed and what people have said in interviews has definitely been corroborated, and some things that come up in interviews that we can't see in the observations, and vice versa. But the strength of having both, of course, is that you don't just rely on one data type. You can hear what people's experiences of what you're observing, and to see if it backs up your interpretation. Yeah. Okay.
That's great. Okay, well, thanks very much, Jamie. And I'm sure that's... Oh, sorry. Of course, please. Are you fine for a copy of the slides?
I can share some of them. I can't share the transcripts, but I'll share the other ones, sure. Yeah, sorry.
Okay, that's great. So thanks very much, Jamie, and I'm sure people have got loads of great kind of thoughts and insights in terms of taking some of these things forward in their own work, perhaps. So please stick around for kind of chat and some drinks, some soft drinks at the front. So thanks very much for coming. Thanks a lot.
Thank you.